Thank you. So now we back to whole body MRI with Nina Tunariu.
Hello, everyone, and thank you. I have no relevant financial disclosures. Bertrand, I'll try my best, but I don't think my talk has so much data than I wish to. Maybe that because I end up always spending time with the patients and I get to know them much more. And whilst I don't have a lot of data, I have 15 years of doing this and getting feedback from the patients and the clinicians in a literally daily, hourly basis kind of thing when I'm at work. This was a painter, and I want to say to you that what MRI is and what the strength of whole body MRI is, because it's a multi-parametric approach. MRI will always be multi-parametric. So here we look at cellularity. Here we look at the fat content, which helps us tremendously in the bone marrow lesions. We have the T2, which helps us with the anatomy. And then we added the spine because we want to be sure that we pick up complications before the patient has a problem. So since I joined Johan around 17 years ago, we never had a paralyzed patient in our clinic because I always can predict, and I will go to Johan and say, I know he's asymptomatic, but in 2 to 3 weeks, this man will come back. So whilst at the beginning, perhaps it was like, you are a radiologist, you have no right to talk. After a while, I think when I say that now, and Aurelius can confirm that, the patient gets radiotherapy. So all of this is around 45 minutes. And this patient has brain metastasis, as you see, has a lot of lung metastasis, pleural metastasis, there near T7. You can see that the cord is very close to the disease, but there is no cord compression. And here you can see the disease is coming out of the bone and it's breaking into the muscles, and he's going to have avulsion injuries. 45 minutes may seem a lot, but I want to remind you an MRI rectum takes 40 minutes, an MRI liver takes 30 to 40 minutes, an MRI prostate in some places takes 40 minutes, and in a DGH, small hospitals in UK, an MRI spine takes 40 minutes. This is his PSMA PET. He was going and he wanted to have PSMA therapy, and you may see here that the brain metastasis was PSMA negative. Some of the liver lesions were PSMA positive, some not, and the bone the same, and I was able to reassure them that the patient didn't need radiotherapy. The other interesting fact, look at the pictures down on the right. Can you see the size of the lesions on MR? They are probably 3 to 4 millimeter. You can see that all those lesions have PSMA activity, but please remember, sometimes it's only half of the lesion that may have PSMA, but of course we can't really differentiate that on a PSMA, and it's my educated guess that some of heterogeneity you see is that the lesions not homogeneously express this PSMA, and you may remember there is data showing that. Now, when we talk about diffusion-weighted imaging, we always talk about tumor cellularity and tumor cell kill. This is a work done on cabozantinib a long time ago in our hospital, and we could see very easily that increase in ADC was associated with necrosis, tumor cell kill. And if you want, you can do a literature research. This is true in every single tumor type. So we know when we see increase in ADC, you have necrosis. And that helps us when we do our biopsies. So right now, when a patient comes to Johan's clinic, the first thing he has, it's a whole body MRI for 2 reasons. One is there something which should worry me and he can't go on a trial? Secondly, where do we biopsy? And you can see in this particular patient, the CT was completely normal, and the lesions we biopsy are the lesions who have very low fat, black on that fat fraction on the top, and very low ADC, i.e. they have tumor cellularity, and that gives us now a predictive value of 93%. So most of our biopsies now, bone marrow biopsies, even if the lesion is 5 to 10 millimeter on MRI, are now suitable for next generation sequencing using this approach. Sometimes when the patient comes to the clinic, and this is what I do outside Johan's patients, so slightly earlier, the first question in the back of my mind is, does the PSA talk to the disease? And in this patient, you may see the PSA drop dramatically. So the patient comes with a PSA of 300, you give hormones, and then just before you start apalutamide, his PSA went to 3 point something. And then it kind of dwindled around. And when we did a PSMA PET and the whole body MRI, because the patient is going on a trial and has both, you may see that the patient has multiple lesions on a PET, and the PET is down there, and you see the SUV of that lesion, it's around maximum 10, 7.4, the mean. And on MR, you can see it has a rim of cellular disease. If you look on there on the top, you may see that's a rim of disease. And that I've seen in every single tumor, which means that this patient is going to automatically go in a category PSA doesn't really talk with the disease. He needs whole body MRI every 3 to 6 months. We are too worried that we will miss PSA, non-secreted disease progression. This is a surgeon, which really upset me at the time because he went and had a exenteration for a T4 disease, and then he went and monitored his disease with bone scans. And whilst his PSA has halved, his MRI showed dramatic increase in bone lesions, and regrettably, he died a year later. And he was so happy about that PSA. And this was the first time, so 10 years ago, when I realized that the PSA was coming from some sub-centimeter nodes, and his bone metastasis never produced PSA. So that's why he was progressing. This is our data, which finally I managed, and hopefully we'll publish it soon. We looked at around 200 patients. We don't do CT and bone scans anymore. So it was difficult to find these patients who had had whole body MRI, CT, and bone scan at every single time point in their story. I chosen bone only because it's more important than the soft tissue. And you can see that the agreement between prostate cancer working group and the whole body MRI criteria was 44%. And if your bone scan shows non-progression, and you see there in yellow, 20% of your patients would be responding according to the MR, 24 will be stable, and the rest of them will be progressing. Reassuringly, every single PD unknown ended up being progression. And does it matter? Well, it does. And I want you to look at these two graphics. So the one on the left, you can see that when we say the patient is progressing in green, it's bad news. And I must say, in 15 years, I have never overcalled the progression. I don't want to be arrogant. It's just the reality. And we use MR so often. The differences between the stable and responding, I strongly believe it's the tumor heterogeneity. I see so much heterogeneous response on MRI that it's almost my first sentence in most of my reports. And again, maybe the other graphic mirrors what you saw with the PSMA earlier. In Professor Hoffman talk, you can see that we saw progression dramatically sooner on MR than on a bone scan. And we have done a calculation, which will be on our paper. We found out that some patients will stay 100 days to up to 2 years on a standard treatment, waiting for the CT and the bone scan to change. So we will save the patients in average of around 100 days of unnecessary chemo-related toxicity. And I want to finish with a couple of questions. So this is a patient who is undergoing a beautiful PSMA-targeted therapy, not a normal one, it's a phase 1 trial. And I want to show you the images. So on a CT, you may see that he suddenly has this multiple new cold bone metastasis. So that's osteoblastic flare, and that's why the RECIST doesn't really care about bone, because you will never be right. I promise you, you can try, you will always be wrong. So don't have an opinion about them. They're there. There are no lytic disease, which means the patient is going to have no core compression. Bone scan, you can see dramatically increase in number. Again, all these lesions were present there. PSMA PETs show dramatic reduction in SUV in all the lesions. Would we agree? And the diffusion got dramatically better too. And the PSA went from 100 to 2. So the patient is doing very well, feeling very well, doesn't have any pain anymore. Now, let's look at these images. So the PSMA, the baseline, it's on the bottom, and the current study is on a top. Baseline has PSMA PET, as you can see, the bigger screen, and then you have the ADC, which is our quantitative parameter, which we know that it has around 10% variation. So it means that if I see a 20% increase, is real. And the other one, it's a fusion between diffusion and T2, so you see where the lesions are. And I want to take your attention to those 4 lesions in the right iliac bone, or 5, right sacroiliac. Can you see the response on a PET? The SUV has decided to be 14 in one, 7 on the other, and then the other ones disappeared. On MR, all those lesions are necrotic with various degrees of necrosis. Some of them have an ADC of 1800, some of them had an ADC of 1600. The water, it's around 2500, just to give you an idea. Look at the node. The node on PSMA PET changed very little. By RECIST was stable, but on MR has much more necrosis, has a lot of fluid around that node, and the patient has new lymphedema. So the question I have to you, why can we not combine this? I don't think there is right or wrong. What do we learn? What is different? All of them had the same SUV at the baseline. Why the lesion in the sacrum and the posterior iliac bone responded better, inverted comma, because I don't know, to the other one? And that's what I'm saying is this can be biopsied under CT incredibly easily using MRI fusion. And how do we show you all of this? So I have a group of physicists, Matthew Blackledge, who works on this. We see heterogeneous response all the time. How do we show it to you? Would you find this kind of maps in which red is bad and green is good useful? But do you need a number? So to decide, as Bertrand said, I don't know how much heterogeneity will force you to change the treatment. So this is where I think the whole body MRI can help you. There is no confounder of flare, so even if I don't have a baseline, if your lesions are necrotic, I know you have responded. I don't have biomarker negative disease. MRI doesn't have specificity for sub-centimeter nodes, but I don't think you care about a 5 mm node when the patient has multifocal disease. It does need a CT for lung lesions. Complications, as I said, renal failure and skeletal events, and heterogeneous disease, and I really do think the future should be MRI PET. And apologies, I want to leave you with this case. This is my last slide. So this is a man, as you can see here, glycine 4+5, PSA 70, started ADT, and then he was moved to enzalutamide. Moved to enzalutamide 2.5 years ago. The PSA was 70, went to 3 at the beginning of the enzalutamide, and is now 0.22. We followed him up with the whole body MRI because, again, I was not sure about his behavior. The whole body MRI shows maintain excellent response at all sites. We did a PET because we thought one of the nodes may deserve SBRT. And the PET got reported as showing numerous PSMA-AVID lesions. And most of the PSMA-AVID have an SUV of 27. Or 10, or 12, including the prostate. And I have no idea what does it mean. On MR, the lesions are very necrotic. The patient is 80, so he doesn't want any biopsies. So the only thing I can is to bring you next year the data. But I would like an answer from my PET colleagues. Why? Is this because he has a flare 2 years down the line? Is this because he's still healing? Is this because he has another disease? Why would you have this pattern of disease? So the bottom line, I feel, is we could help each other and understand better what we are seeing. Thank you, Bertrand. Sorry.